What I'm going to do today is talk about advanced healthcare directives, just to kind of review, because everything, for me, end of life issues combine a lot of different things. For those of you that don't know me, and that's everybody who wasn't here when I first arrived, I'm Jan Wilson. I'm a volunteer with Compassionate Choices, which is a national organization, as well as End of Life Options New Mexico, which is a local organization, local to the state, that was formed after the law was passed. And with me, I have Randy Lowenthal, who's here. So if I can't answer a question, I'm going to call on Randy to do so. I think I forgot to tell you, Randy. So without further ado, I think we can get going. I just have to hit the right buttons. Okay, again, this is who I am, and I'm part of End of Life Options. And what is End of Life Options New Mexico? Our organization is striving to make sure all New Mexicans have accurate information about end of life options, all end of life options. Although we were asked to do a program on just the medical aid in dying law, we felt that what we need to do for all of our presentations is to give everybody all of the choices, because we're not here to tell you what to do. We're just here to give you some information and hopefully make you start thinking about it and having that conversation with your loved ones and friends. As you can see on the screen, we have our vision and our mission. So we're going to talk about an advanced healthcare directive. Again, you can see on your screen what it basically is. For those of you that are in the audience right here, how many of you have an advanced directive at this point? Okay, this is my best audience so far. Next question, have you looked at it recently? No. Okay, that usually gets a lot of people. And because we're going to talk about how important it is to keep reviewing that document, because what you think you want today may not be what you want tomorrow. And if you don't change it and send it out to people, you're going to be stuck with what you thought, what, a year ago, 5 years ago, that you wanted. Typically, an advanced directive is a combination of a living will and a medical durable power of attorney. You also can add some other documents with it, so you can always add to your advanced directive. Okay, who should have one? Good question. Most people say, I'm way too young, I don't need one. But you know, people get sick, people die at any age. So don't wait until you're old or sick.
I am old.
So are we. But if you wait till you're old and sick, a lot of times you may not have a clear picture or a way to express what you want. So it's better to do it now while you are, well, I'm assuming you're all very competent. Why do people even bother with advanced directives? First of all, let me say, they are not 100% guaranteed. They're not foolproof. You may end up getting some treatment that you don't particularly want because it's an immediate reaction of your healthcare personnel. Okay, I just need you to know that so that you don't go saying, wait a minute, Jan Wilson said that if I write this down, you're going to do exactly what I want. It may not happen that way, okay? But it does help with planning. It helps clarify your priorities and your wishes, because you have to think of those as you write your plan. It does have a legal authority. It can resolve questions. It helps to increase support a lot of times among your family and the medical personnel. If nothing else, it can bring peace of mind to both you and your family members. Think about it. Well, if you're in the ER or in ICU, isn't it better that your family can concentrate on you and not what the doctor wants to know? Now, I don't know about your family, but my family, we're not always on the same page, especially with me, I have to say. So this can bring some help to minimize conflicts among your family. If you've written down what you want and you've talked, we're going to hear that a lot. If you have the conversation and you talk to your proxy or your family members, they're more apt to not have any fighting while you're there in the ICU unit, because they know what you wanted. You've explained why you want it that way. Doesn't always work. And you may have some families that you can think of that nothing will work, but you have a better odds. And in some ways, it helps prepare for the future. It will, you can write down what options you might want, even if they're not available today or are legal today. You might not get them, but at least they're written down somewhere. So what are the steps to writing an advance directive? For 8 years with Compassion and Choices, I used to go around and that was my whole presentation. I'd spend an hour to an hour and a half talking about advance directives. We're not going to do that today because I know you don't want to stick around for about 3 hours. But if you need more information or want me to come back, I'd be very happy to come back and do a whole presentation on advance directives and explain a lot more. I'm going to go briefly through these steps to writing an advance directive. The first step is to determine your values. What makes your life meaningful? What brings you joy? Because everything kind of flows from that. The next thing you need to do is choose a proxy or a substitute decision maker, power of attorney. There's all kinds of titles. You can ask the person what title he or she would like, and you can have more than one. One thing I will say though, if you have a family of, let's say, of 4 or 5 children, I would not make them all your proxy. That can lead to big problems. But you can put down 1 or 2, a backup person perhaps. I'd also like to mention real quickly, your family members may not be the best person either, and only you know how they might react. Oops, she's coming back.
Sorry, let's try stopping the screen share and restarting it so that we can get, so the Zoom folks, sorry, you're not seeing the screens advance and we are here. So we're gonna see if we can fix that.
I know just enough information to be dangerous here.
Let's use this one and you can manually advance it. And then you can just click down.
Okay, we'll go to where I want to be.
Yeah.
Can I put it on slideshow?
Well, I think that's
I think it is.
honestly. So why don't you leave it on this?
Okay. Okay, it does, my screen seems to be frozen. Okay, there we go. Okay, where were we? Oh, choosing your proxy. Sometimes family members are not the best people to have because they're too invested and they may not be able to follow what your wishes are, even though they say they're going to. Okay, so keep that in mind. In a lot of my presentations, people say, how can I do that? How can I not pick my daughter or my son or my brother? They're going to be so hurt. And that maybe what you need to say is, I'm doing you a big favor. You don't have to make all these decisions. And that doesn't mean I don't love you. So you can get around some of these things. And then you want to talk about what kinds of treatments that you might want. 8 years ago when I started, we used to spend a lot of time going through all the various possible treatments. And that seemed to make sense. However, now we're saying, think more about it in general terms. Do you want to be on a ventilator, let's say, for a long time or just a short time? A lot of your decisions are going to be situational. And medical science has progressed at such a fast rate that you just don't always know what's around the corner. And so therefore, if you make some general statements about being able to go do whatever it takes to get back home, let's say, or try something for 2 weeks and then reevaluate, that's probably a better way to put it than to say, no, I never want CPR, or yes, always try CPR. There may be some times when that's not the best alternative. Then once you've thought about all of this, then you need to document your wishes. Now I brought this, and I know the people at Zoom, can they see me holding things up? They can't really, can they? In the small view. Okay, great. I really recommend getting this booklet from Compassion and Choices. It's my end of life decisions. It goes through a lot of what I said, but in more detail, and it has worksheets that you can use that will help you make some decisions.
You got those forced to take?
I do.
All right.
And I brought extras for those of you who are at home and want to come into the library later. Now, if you go to Compassion and Choices, they have the actual health care directives for every state. And you just pick the state that you want to do it for. And then you can fill it out. I've also brought some of these so you can get started. So once you document your wishes, you can do it in the written form. You can do it on the video. What you do not have to have here in New Mexico is you do not have to have your doctor. You do not have to have a lawyer. You actually don't even need a form. You can write it all out on your own if you like. We don't recommend that because too often we might forget what else we want to put in there. You don't even need to have it notarized or witnessed. But I'll tell you, it's better to have these things done, especially for witnessing. So there's no question that you were okay when you wrote this. So once you document your wishes and you've signed it and you've dated it, now you have to give it out. Don't put it in that desk drawer that nobody will ever find it. Make sure it's available. Make sure your proxy has it. Make sure your healthcare provider has one. I even give my siblings a copy of mine, even though they're not my proxy. No, thank you. But this way they already have an idea of what I want. And I'd like to tell a quick story about another place that I found would be good. I suggested to people, put it in your glove compartment. Or when you go on a trip, put it in your suitcase. My husband and I, 6 years ago now, were wandering around the boonies of Arizona looking for ghost towns. And he didn't feel so great. And he got up the next morning and he said, you think we could go home early? And I said, sure. He decided to call the Blue Cross Blue Shield nurse that you can call. They're on duty 24 hours a day. She said, chew up 2 aspirin and call 911 now. We did that. The EMTs came. They ran their little machine. And the head guy says, I sense an anomaly here. And I said, an anomaly? I have never liked that word since, I'll tell you. In fact, his reading was so bad, they said, we want to take him right up to Tucson to the heart hospital and bypass our regional hospital. We better get going now. So up we trotted. Well, we rode in a car. He was in the ambulance. We got there, and I had taken my own advice, and I had my documents in the car. So I grabbed Bob's advance directive and went trotting in. Next question, right after, do you have insurance, was, do you have an advance directive? I was able to give it to them. They made copies, and I was on my way to see my husband. I'm not sure what the paperwork would have been like if I did that. No, No. Good ending, good ending. It had nothing to do with the advanced directive though, because he didn't even get close to that. But
Yeah.
he did end up with quintuple bypass surgery. So, but that's a whole nother story that you don't need right now.
Okay.
So think about places that you would like to have your advanced directive in. In fact, I don't have kids or grandchildren. So you can imagine what my refrigerator looks like. I don't have these cute little pictures. I have my advanced directive hanging up there. Lovely. Okay, and the last thing on this list, have the conversation. And you're going to get tired of me saying that, but that is so important. And you have to have it more than once because a lot of people don't want to listen. And it's hard to do. And by the time you've done it a few times, you'll get it down where you can say exactly what you want. We do have some resources. Again, I'm going to use Compassion and Choices, but there are a lot out there. They have a whole section on their website about dementia and what kind of choices you might have if you get dementia. And just a sidebar, if you've already got dementia or you're not competent, as they say, you can't write your advanced directive. You have to be competent. Another reason for writing it now and not waiting. And they are really ahead of everybody because they also put together a COVID-19 treatment sheet. It's a one-pager that tells people, do you want to go to the hospital? Do you want to try to be at home if you can? Do you want oxygen? Do you want a ventilator? Some simple questions only to be used if you happen to get COVID. Have any of you seen these forms before? Okay, a couple of people. It's called the New Mexico Medical Orders per Scope of Treatment. And yes, we have those here too. It's basically a doctor's orders. And that makes it different from your advanced directive, which you can write and you can update anytime. This you have to do with your doctor and or healthcare provider and have that person sign as well. What's the advantage of this? Because you can see it, it's only one page. It gives very immediate orders. And also a lot of our EMTs and personnel, emergency personnel, are being trained to look for this nice bright green sheet. And this they will honor with no problem. Trying to read through our advanced directives might take a lot longer. Okay, so you might keep this. If you're pretty healthy right now, your doctor might not want to even sign it yet. But at least you have it in case something happens and you need to have it done. There are a couple websites up there on the screen. Compassion and Choices, I recommend because, boy, they've been in it for a long time and they have a lot of great information. Death with Dignity also has great information. And the Conversation Project is good because they really give you an outline of how to talk to people, how to talk to your family, how to pick a proxy, how to talk to your doctor or healthcare provider. It's a really great site, and I do recommend it. Now we're going to kind of switch gears. Advanced directives are used when you can no longer speak or can articulate your wishes. And a lot of times you are unconscious. Our next section is going to be on all the different options we have here in New Mexico as we approach end of life. Again, advanced directives you do now. And depending on your philosophy of life, you may want to live another 10, 15 years. What we're going to go into now is when you know that there's been a serious diagnosis for the most part. So these are all the options that we're going to go over today. And I think I have the room until about 7 o'clock tonight, right? Just kidding, just kidding. Okay, all or nothing or in between. Some people want every minute that they can get, whether it's to be with their grandchildren, to take care of their animals, whatever. They'll do anything, and they'll ask the doctors for more and more treatments. They might even want to do is be in a study for experimental treatments. That's great. And I'm certainly am not here to say people should not do that. I just want you to know that. But you can also decide to forego treatment. One example, and I'm taking examples from friends I have and my family members, people who have had cancer and it's come back a couple of times, they go through chemotherapy and radiation, and they said, I can't do this anymore. So they decide the next time this happens, they are not going to do that. When my mother was in hospice, she said, if my kidneys get so bad that they want me on dialysis, I'm not going to do that. So you can forego treatment. You can also stop treatment if you're already on it. Let's say you're on dialysis and then you get another really bad diagnosis. You may want to stop dialysis because it's not doing you any good at that point. And there's all kinds of examples we can use. But it's up to you to decide the balance. Are you having a good life with your treatments? Would you have a better life without the treatments? And it's for you to decide. And it's not easy, folks. I hope I'm not implying that any of this that I'm talking about is easy. Okay, how many of you know about palliative care and hospice care, or think you know something about it? You've all heard of it anyway. Well, in some ways, they're very similar in that they're self-directed, they're patient-oriented. They really concentrate on quality of life, as defined by you. Not what I consider quality of life, but what you consider quality of life. And they treat the whole person. It's a multidisciplinary team. They usually have, besides all the healthcare providers, they have social workers, chaplains, and other people to help you with different parts of your life. And they involve the family. And again, it's who you consider your family. Okay, palliative care is a little different from hospice, though, in that it can start as early as the time of diagnosis of a serious illness. And you may contract an illness that is not terminal. It does not, but palliative care does not require a 6-month prognosis. But it still has a collaborative determination of goals for your care. And this is where, if you've done the advanced directive, you've already thought through a lot of these things. It's not new to you. And then they also take care of their management of your physical problems, psychosocial problems, spiritual needs, if all those things are important to you. But they focus on the quality of life. Mm-hmm. And it includes loved ones. And you'll find that the hospice does too. The next thing is a big difference between palliative care and hospice. In that with palliative care, you can still go through all the treatments that you wish to have. You can going through things that might cure whatever you have. But if you need comfort care, you can ask for palliative care. Now, I should say that some smaller hospitals may not have a really extensive palliative care team or department. Something to ask about. Now, it could be a one-time consult that you would want, or it could be ongoing, depending on how you feel about things and your condition. You may do it while you're in the hospital for a particular situation, or they may come out to your home. Now, it does not pay for any medications, supplies, or medical equipment, okay? Even though they may suggest some things. Hospice, on the other hand, is really more of a philosophy. It's not a place. And one thing that the person that I talked to about this said, make sure you tell everybody do not wait till you're close to dying. And I don't know if you've been in this kind of situation, but I have, where somebody says, I don't want to go into hospice because that means I'm giving up. That means I'm going to die soon. Not necessarily so. On the other hand, my mother begged her doctor to put her into hospice. And he was able to do so legitimately because she knew she'd get a lot better care than she would living at home alone. So there's 4 levels of care. Most people are in the routine care, and you've probably seen that a lot, where a doctor or nurse comes in once a week, once a month, whatever you need. You might get a nurse's aide to come in and help with certain things. You have access to the other department heads. But sometimes your symptoms might just get really bad. And so hospice has some inpatient care for unmanageable symptoms. And a lot of times they can, by taking you, let's say, into a hospital setting, help relieve those symptoms. Sometimes they can't. And then all of a sudden you're back, maybe back at home, but you need continuous care for difficult symptoms. So that's another layer of the hospice. They also have something for your family members or caregivers, and that's called respite care. I haven't had to do this, but I can't imagine having to care for somebody 24/7. It has to be very wearing. And this is what you hear. And sometimes having your loved one taken care of for 4 or 5 days so you can go away, that can bring a whole new fresh look to coming back and caregiving. So who qualifies for hospice care? With hospice, you have to have a 6-month life expectancy if the disease runs its normal course. And we all know the people who have gotten diagnoses that all of a sudden are still around 5 years later. Or somebody that say, oh, don't worry, you've got months to go, and 2 weeks later, they're dead. So it's not an exact science, but they take what they generally know, the doctors generally know about certain diseases. And if you're within the 6 months, that's why physicians must certify whether or not you're eligible. And we talk about the people who have gone more than 6 months and they're doing so well, they need more time. And so they can go through recertification at intervals. The big thing about hospice, though, is that you have to agree to forego acute or aggressive treatment for your diagnosed disease. Now, this doesn't mean that if you fall out of bed and break your hip, they're not going to take you to the hospital and make sure that they can fix it or make you comfortable. But they're not going, you can't go and have, let's say, more radiation for your tumor, because if that's what your diagnosis was cancer, you can't have that. But for other things that you need comfort for, sure, they're gonna help. And there's no requirement for a DNR, which is do not resuscitate, but most patients end up, as they go along their path, choosing that. And look at all the things that hospice provides. Why wouldn't you want that the full 6 months? And some people just thrive, if you will, having hospice, because you get specialized symptom management. They look at you as the person, as the patient, and you help them decide what's your best goal. They also provide medical equipment, hygiene supplies, certain medications for that disease. You may have to pay for medications if you catch a cold or something like that. And look at all the people that you have at your fingertips. Your physician or other provider, nurse, hospice aides, chaplains if you need it, social workers, volunteers will come in and either help with diversion, maybe help with some light housekeeping even if you're all by yourself, run errands, allow your caregiver to go out and get a manicure while the volunteer sits there and watches and talks with the patient. So there's a lot of different things that the hospice will do. And they have a bereavement program for the family. Another indication of how they pull everybody together. Okay, when you're looking for a hospice, you need to be pretty proactive. Ask a lot of questions. These are some that seem to always come up. How often am I going to get professional caregivers? Well, a lot of times at the beginning, they may come every 2 weeks or once a month. But as you get sicker or show more symptoms, they may come more often. Will the hospice approve of as much pain reliever as needed? Any of you remember the old stories of the nurses saying, I can only give you this much morphine because we don't want you to become addicted? I think a lot of that has gone by the wayside. But that was the first question I asked my mother's hospice team. And will that hospice support voluntary stopping eating and drinking or medical aid in dying? That's going to become more and more important as hospices have to grapple with what kind of policies they want. And guess what? Compassion and Choices has some resources for you, as well as there's plenty of books and other sites, but they have a whole section on questions for hospice and how to find some hospice care. We put this in capital letters because the hospice worker that I talked with said, this is real important. All hospice care is palliative. It's all comforting. It's all made for quality of life. But not all palliative care is hospice, because palliative care allows you to continue to get treatment and hospice does not. I should have marked some of these slides with asterisks and balloons so you know what you're supposed to remember when you go home. I might do that next time. Remind me, Randy. Okay, palliative sedation. A lot of people have never heard of this. It's a use of special drugs, basically sedatives, and it's to relieve some extreme suffering by making a person calm, perhaps unaware, perhaps unconscious. As people go through different phases of their disease, they might get very anxious or have exacerbated symptoms. It's done for patients who cannot be controlled by any other treatment that the hospice, it's usually people on hospice, or it could be in the hospital, that they can't control these symptoms. And it could be used in patients who are near to death to make them more comfortable. Again, it's all situational. However, the difference is it's not intended to shorten your life or to cause death. It's just to get rid of those pesky little symptoms that are giving you such grief there. So what are the benefits? It's geared toward giving that relief. That's it. And to prevent unnecessary suffering. Who qualifies for it? Well, people, a lot of times they're on hospice, but people who have unrelieved suffering, physical or mental, and no aggressive care is effective in it anymore. Now, the one thing that you're a proxy, or you can put this into your advanced healthcare directive, that if you get to a certain point, you would like medications to keep you calm. And that's something that I've added into my advanced directive, actually. And this is one case where if the patient doesn't have the capacity to make this decision or verbalize it, it can be requested by the proxy or the family. Okay, how does it work? Usually they start with a very small dose of the medication, kind of like a first stage anesthesia. Maybe some of you have had some procedures where you're kind of in this twilight zone. They start with that. If that's not enough, they gradually build up until your symptoms have disappeared. On the other hand, if everything is going well, they'll start to decrease that medication until they get to the point. And some people, not very often, I have to say, actually can be weaned off of this palliative sedation. However, because it's usually given towards the end of death, that doesn't happen very often, as you can imagine. So let's move on to voluntary stopping eating and drinking. A lot of people don't know too much about this. Voluntary stopping eating and drinking. One thing good about this particular option is that it's legal. It always has been legal. Once they have the patient's right to refuse treatment act. It allows you as the patient to take control and have time to say goodbyes. And it allows most people to die at home, which is, if you ask most people, this is what they would like at the end. And it does not need a 6-month prognosis. Okay, who might choose this option? Well, you hear about it a lot with people who have a 6-month, but they don't have a 6-month prognosis. They might have ALS or Parkinson's or Alzheimer's, and they know what's going to be happening. And they know they are going to not have the quality of life they want, even though they have that 6-month quantity of life. It's usually a person who fears loss of their independence, loss of their quality of life. I would imagine it's a very hard decision to make. And you have to be very determined, because you're going to have to maintain not eating or drinking until death. You can't just do it for a few days and then say, I don't think I like this so much, because depending on your situation, some of your organs may have already started to shut down. So you have to be very determined.
I got to eat.
Pardon?
I got to eat.
Yeah, well, then this is not the option for you. The person should have some support necessary, because especially at the end, you're going to become weaker and you're going to need 24-hour care. What are the challenges? Some healthcare providers do not want to participate. They do not want to have anything to do with you if you choose this. Some facilities will not support this. It really requires strong commitment, especially at the beginning. And it's extremely difficult for your loved ones or your caregivers to withhold food and water. That's against our nature. We want to give food and water to people. And another quick story, a friend of mine, her mother chose this option, and she was doing pretty good. And then all of a sudden she got a care worker who started making bread and brownies and things like that. And Carol had to go and tell them, you've got to stop this. You know, it's almost like creating torture for people to have these wonderful aromas when you are trying so hard to not eat. And it does require some medical support to alleviate the symptoms at the end. Expectations, again, it's a little situational. Usually death happens between 5 days, 14 days. 10 days seems to be about the average, though you do hear stories of people lasting 3 weeks or so. But after the first day or two, it's not painful. And though it does still take some discipline not to grab for that chocolate or that glass of wine. Hospice may support from the beginning, or may wait until you've done it for a while, and so you are closer to being in the dying process. And interestingly enough, this is not considered suicide. And death certificates will specify your underlying conditions, so you don't have to worry about that. But there is some prep necessary. First of all, you want to have everything in order. You may want to make a video to really tell people what you want and why. You need to enlist the support of a healthcare provider that will help you, and review your current meds with them so you can discontinue taking meds. Any meds that you have to be on, try to find a different way so you're not having to take water to take your medication. And then just kind of a touchy-feely piece is surround yourself with your comfort items. You know, if there's favorite videos you want to watch, some music you want, your books, invite your friends that you really want to see over to come and visit. But gradually, if you decrease your food intake, it makes it a lot easier. In fact, one webinar I attended, they said they are recommending that people actually use that colonoscopy prep that's so awful for some people. But it does get you cleaned out, which will make it easier for you not to have food. You need to care for that person because they're going to be drying out. So you need to keep their lips moist. You may have some oral sprays they have out now. If it's a small enough room that they're going to be in, having an air humidifier. You, of course, can give ice chips or sips of water, but that's just going to prolong the process. We do not recommend that. But you might also have somebody do massage or just some touch with moisturizing lotion because your hands and your skin are going to start to dry out. Most discomfort can be controlled with medications, and that's another reason for being under a doctor's care or a hospice, is so that as things progress, you might be able to get more medications. Okay, need a drink of water before this one. Medical aid in dying, which is actually what we were invited to talk about, and I am finally getting there. Let's read it together. Medical practice whereby a mentally competent, terminally ill adult can request from a medical provider a prescription for medication that they may self-administer to bring about a peaceful death. This law became effective in June of 2021. As of now, what End of Life Options New Mexico knows, there's been over 30 ingestions. Now, there's been some probably done by hospices that we don't know about, but those are the ones that have come through our offices and through our volunteers. To me, that shows that New Mexico was ready for this law. This is just a map of the United States. The bright blue are the jurisdictions that have this as a law. You see we're number 11. And I believe there's at least 15 or more states that are now introducing bills into their legislatures this year. So who knows what will happen then. It does have to go through a lot, though, as Randy can also attest to. We went through 3 legislative periods trying to get it through because it's got to go through committees and everything else. Who qualifies? And this is real important. You have to be a New Mexico resident. You have to be 18 or older. You have to have the terminal illness diagnosis of 6 months or less. So it's a lot like hospice requirements. You have to voluntarily make this request. You have to be able to self-administer the drug. And we're going to get into that a little bit later. And the biggest thing is you have to have the capacity to make that decision and to communicate it, because you have to be able to tell people that this is what you want. Unfortunately, that means that people with dementia cannot take advantage of this law. It's totally voluntary for everybody involved. There should be no coercion for the patient. If your provider opts out, they have to inform you and refer you to somebody else. And this is important, transfer medical records. Again, with COVID, there's nothing else to do but go to all these webinars. And there's been stories of doctors who have refused to help one of their patients and then refused to give up their medical records so they could go to another doctor and not have to start the whole process over again. If a healthcare entity prohibits me, like a hospital, or a nursing home, they need to post this policy on their website. And then any other relevant materials. And I think this is important too. And I have to applaud New Mexico for putting this in. If a healthcare entity cannot forbid an employee to help a patient as long as they do it off premise and outside of their employment. So a hospital that does not support aid in dying cannot penalize the actual healthcare provider. So we have some unique features, and in fact, several states that have had this on their books for a long time have gone back and have legislation now so that their laws are going to be more like ours. One, there's only one waiting period, and that's the 48 hours after your prescription is written, that you have to wait to have it filled. It's not 15 days. We allow nurse practitioners and physician assistants to be one of the two medical providers that will sign on to this. This is brand new. And as we know here in New Mexico, that's really important since you get out in very rural areas and they don't have a lot of the doctors. And to force people who are dying to go into Santa Fe or Albuquerque or one of the cities is very difficult on the patient. And there is a hospice exemption. So if you're already in hospice, that means you've already been certified to have a 6-month diagnosis or less. So that counts as one of your providers. And you only need one written request. So what does your provider have to do? They have to tell you about all of the different options, kind of like what I'm doing today. And they document all your qualifications to make, so it's all written down that you do qualify. In the law itself, and you can get copies of this, there's a request to end my life in a peaceful manner. And you can use that form right from the law, or you can write something up that's very, very similar to it. It has to be completed, signed, of course, witnessed by 2 persons. And they can't be the people that, like if you're in a nursing home, they can't be all the nursing home people. And the provider must enter it into the patient's health record. And of course, the provider has to provide reporting to the state. Some other features, either the provider, if either of the providers think there may be a mental health component that needs to be looked into, then we get a referral to a mental health professional. And you go no further in the process until the professional says, yes, this person is competent and can make this decision. Oops. How did I get there? Sorry, I pressed the button. Let me see if I can get this back up. Okay, medical aid in dying is not considered suicide. This is why we call it aid in dying. And it will be on the death certificate, will be the disease that you ended up dying from. And this slide here shows that the difference, we believe, that medical aid in dying versus suicide. Now, I don't think I need to go through all of this. A lot of the things we've talked about before, but one thing is that death is gentle versus very violent in a regular suicide. And we heard testimony from some people whose parents or grandparents really couldn't abide the suffering that they were going under. And they would come home to find that they had taken their own life very violently. Personally, I think that should not have been allowed. You know, we have to help people do the best they can at the end of their life, not make it difficult for them. One thing with medical aid in dying. There's normal grieving is the usual thing because you've been part of it. The family has been part of it. With suicide, too many times people say, could I have done something to help prevent that? I didn't know what he or she was going through. And so you do have your friends and your family support with medical aid in dying versus suicide. Excuse me. Okay, let's talk about the ingestion. People tend to have questions about this. Excuse me. First of all, there's the state laws have no requirement for the exact mixture that is the medication that we're using. And indeed, I'm not going to talk about it either in specific terms because it changes often enough. Sometimes the medications are no longer available or become too expensive. So we're not going to talk about specifics, okay? And the medication comes in a powder form usually that needs to be mixed, and it's compounded, so you need to go to a compounding pharmacy. Only ingestion is allowed, and there's different ways to do it, but you can't have it go in, let's say, into your bloodstream through an IV or an injection. Ingestion needs to be completed within 2 minutes. You certainly don't want to fall asleep after taking one of the medications and not finish. After self-administering the medication, the person usually falls asleep within 20 minutes and then dies painlessly and peacefully within an hour or two. Okay, so there's a timeline that you have to adhere to. Patients need to stop taking medications about 12 hours before. Have your last big meal maybe 5 hours before so that your body is empty and can absorb it better. 1 hour before the time that you had set up, you take some prescribed medication that will help with anxiety and nausea. Okay, it prepares your body for the next medication. Immediately before the time that you want to take it, your caregivers are going to start mixing the powder with 4 ounces of liquid. And for some reason, they like to do apple juice, and I'm not sure why, but you can use other beverages. And then once it's given to the patient to ingest, you need to do it within 2 minutes, and the patient takes the liquid medication. Now, people have asked, well, what happens if, because of your disease, you can't swallow anymore? Well, they have other options for people who cannot swallow. There's feeding tubes, rectal administration, but as long as it's being ingested by self-administration, it's okay. Now, I'm not a clinician, so I'd rather not go into all of these different options, but we can certainly look it up. What can you expect after the ingestion? And this is some protocol that's recommended by the American Clinicians Academy on medical aid in dying. And they do a lot of research, they take a lot of the data, and they provide a lot of information for the different states who are trying to write their protocols. So 20 to 40 minutes, people tend to fall asleep, and they go deeper and deeper into sleep. So within minutes to hours, they're in a coma. Death usually happens within 2 minutes to 8 hours. And you can see on the slide, the average time is 1.7. That's pretty specific, I think. 85% of people die within the 2 hours. There's always going to be few people because of their makeup of their body that don't fall within those parameters. There's some barriers. You have to get your medication at a compounding pharmacy. There is a cost to it. Right now, it's about $750. Again, I'd rather you didn't quote me because who knows what it's going to be in the next few months. But there is a lack of Medicare coverage because it is not a federal law, so Medicare cannot pay for it. Some states have started writing it into their Medicaid protocols that it will be paid for. I'm not sure where New Mexico stands on that. Some pharmacies might be owned by faith-based organizations who refuse to participate. And some pharmacists within regular pharmacies may refuse. And as we said before, everybody has the ability to opt out of this. Waiting period, we only require the 48 hours between when they're written and when they're filled. We do recommend that people not fill them right away if you're not going to ingest them right away. You don't need them lying around your house. Okay, how can you access MAID? Well, you can talk to your provider now and ask them whether they would support you if and when the time came. If you're ready to consider MAID, you can call us at End of Life Options New Mexico at 505-393-1321. And I have these brochures here. And for those of you at home, they'll have them here at the library. It has more information about the organization and how to access them. Then you do have to fill out the request form. Here in New Mexico, 2 providers must agree that you qualify. A prescribing provider and then a consulting one that attests to the fact that you are competent and that this is voluntary and that you qualify. Some patients have reported that having the prescription can bring them peace of mind, and then they never take it. They feel so relieved that they have the control that they go along with what happens naturally. And I'm sorry, I don't have the most recent numbers as far as percentage of people that use this. And I know at one point it was like less than 1% of the people go through the process. This is in Oregon. And 1% of that 1% actually did it. Very, very small number. But aren't we glad we have it as an option? So what can you do now? Here we are again. Have the conversation. It's so important. Tell people that this might be what you want or not. I know my mother always said, I think everybody should have the option. She says, I don't think I would ever use it, but I think it's good to have the option there. Make sure you've created or reviewed all of your end-of-life planning documents. And again, appoint that surrogate healthcare decision maker and speak with him about what you've decided, or her. Now, you cannot include MAID in your advance directive per se, because advance directives are used when you're no longer conscious. You have to be conscious in order to do aid and dying. But it doesn't stop you from putting a little paragraph in there about what you think you would do and why, and it just adds to why you picked certain treatments. So talk to your providers. Gee, do they need more information? I just heard that there are still some doctors in California where it's been legal for 5 years. Have never heard of it. And that's what we're trying to do as an organization, is not only make sure all the public knows that these are the options, but that all the doctors and other healthcare providers know what's there. So you can direct them to our organization. Now, if they say there's no way I can participate in this, is that going to be important enough for you to find another provider? And it may be. It was for me. I do have to admit, being down in Albuquerque, I have a slightly larger pool of doctors to choose from than you might up here. But it's good to know where your doctor stands. And if you keep the same doctor, ask him or her every now and then, have you changed your mind? Have you looked into this? Can I count on your support or the support of the practice? Before you select a hospice agency or another long-term care facility, also ask them if you're really serious about possibly needing this option. That's what happened when I go off the lanes. Anyway, I want to thank you for your attention and your support. And what I'd like to do now is open it up to general questions for maybe 15 minutes. And then if anybody has some more personal kinds of stories or questions, we'll go off the recording. But we thought we'd record some of the more general questions, if there are any. Okay. There we go. So does anybody here in the room have a question for me on any of this? It's a lot to process, I realize. And if it's like me with my insurance agent, it makes sense right now that you go out the door and you say, what did she say? I actually have my card here, or you can call End of Life Options New Mexico if all of a sudden the question comes to you that you think we can answer. Okay, we're not just going to walk out and leave you. Okay. Any questions? Any questions from the Zoom people?
Can you hear me?
I can, yep.
Okay, should I take my turn or wait?
I think you're on, Pam.
Okay, I have a couple of questions. One is involving the Advanced Care Directive, and you suggested like in your glove box or whatever. Can I keep a digital copy of that on my phone?
Yes, I didn't get into that because I wanted to keep the that section fairly short, but a lot of iPhones have a special app that you can put your medical information as well as your advanced directive on there. Yes.
Okay, thank you. How long is the medication usable? I know it's supposed to be a 6-month window, but as you said, some people live much longer than that. So if I get a prescription for this and I got it filled, is it something that I can keep for a period of time, or does it have to be used within that 6-month window?
I was kind of afraid somebody would ask that question because I had not found the answer yet. And I'm not even sure how many instances there have been of people holding on to the medication for more than the 6 months. A lot of it's going to depend on what the actual medication is, but that's another reason why we would recommend that you wait until you get close to the time that you think you would want to use it, so that you don't run the risk of it expiring.
Okay.
Randy, do you have any?
Oh, I have one.
Okay.
Oh, I have one more.
Okay.
You have to have a provider and someone else to sign off on this for everyone.
Right.
Let's say I have a primary care doctor who's okay with it. Can I use one of the, say, nurse practitioners or physician's assistants in that same office to be the second person? Or does it have to be totally outside of the office?
As far as I know, it's as long as it's a different person, you're okay. I can double check on that. And if the answer was not correct, I will get back to you.
Okay, and then let's say I don't really have that option, I have a doctor, but there's nobody else to ask in that office or clinic. Will End of Life Options New Mexico help me in finding that second person, or is that totally outside of your realm?
No, actually, we have a whole committee that is working on building up a list of healthcare providers who support aid in dying, as well as pharmacies that would support and help you out And they would do that. There may be an additional cost if you get a provider that is not one of your own providers.
Mhm.
But I know that we have at least one name of somebody who feels so strongly that this should be an option for people, that she will do that.
Please share such information with us here in Jemez so we can put it on our website. I would appreciate that.
What information?
Anything that you get along those lines, like if you develop this list of people that are supportive, we can share that on our JAIP website.
Okay, as far as I know, we are not coming up with publicized lists.
Okay,
So you need to work with our volunteers who are our client support volunteers and talk with them. And if it turns out that you need some reference, then they will provide it. That's not something we want to publicize. I'm sorry.
okay, thank you.
Good questions, though. Any other questions that anybody's come up with while we're standing around here?
Once we have the information, I think we can make a decision.
Okay, yeah, and I do want to remind people that the decision you make today or tomorrow can be changed. And it should be changed if circumstances warrant it. Okay, one thing I did not mention on the advance directive that I would in normal circumstances is that when you've finished distributing it to people, put those people or wherever you put your advance directive, put it on your copy of the advance directive. So if you do make changes, you know who to send the changes to. If you're like me, if it's a year from now, I'm not going to remember who I gave it to. So I need to make sure I have a reminder.
Mention.
One wonders some days, doesn't it?
Well, thank you.
Well, you're welcome. I hope I explained things well enough. One to that you're not worried about things, but also give you a reason to be thinking of it. The more we can plan now, even if we change things, the better it is for us and for our families. So thank you very much for coming today. And if you come up with any other questions, please ask me. I do have the materials here that you can take with you, and I'm leaving extra ones that they can keep at the library for people who were at home.
Your card's here too.
And I have my card, yeah.
Thank you, Jan.